Ah,
Over to you, Rosana Trivino-Perez, social
thank
worker,
you.
UCLA Integrated Substance Use and Addiction Programs.
Thank you very, very much for that. I'm very happy to be here today, and we're going to be talking about substance use disorder and addiction, as the title says. I'm going to give you a little roadmap so you know where we're going today. Just a little bit, I'm one of the clinical trainers at ISAP, and I'm working on a state demonstration project here in California for Medi-Cal, and it's for contingency management. It's a state demonstration project. So that's one of my major projects, but I do a variety of training for ISAP as well. And as Kelly said, my training is in social work. I have a master's in industrial organizational social work from the other school, University of Southern California. So there you go. Okay, so let's get started. Let's look at the roadmap for today. I like to give a little roadmap. We're going to start with another little icebreaker in just a bit. And again, it's really a warm up to invite you to make this training as interactive as possible. I know it's a large group, but we'll use the chat in order to kind of have your responses and kind of set a foundation for the discussion we'll have at the end. Okay, so this is our roadmap. The icebreaker, we'll touch on what happens to the brain with substance use disorder. We'll talk a little bit about that. We'll also touch briefly on some evidence-based modalities. We'll go review those, and then we'll discuss research on stigma and how that impacts treatment and recovery. Then finally, we'll open it up for that discussion that I was mentioning. In terms of a disclaimer, this is a disclaimer we use at UCLA. I'll give you the nugget, one of my favorite words here, that the views expressed by staff, external consultants, trainers, speakers don't necessarily reflect the official policies of UCLA ISEP's funders, nor does the mention of any trade names, commercial practices, or organizations imply endorsement. That's not going to really happen today, but I need to have that a disclaimer. All right, so we'll start with this, and if you would enter into the chat. So what's the favorite part of your job? If you think about it, what are some of the things you enjoy? Another way of maybe asking the question or like, what are those parts of your role that you feel most connected to in terms of your values and your passion? So I think that's another way of asking it. That resonates for me a lot. I'll give you about a minute to kind of enter into the chat what comes up for you. Those things that, yeah, I like that are most connected to your values and passion, and therefore you enjoy the most, and they are your favorite parts of your position. Creative thinking, direct patient care, learning things. Yeah, I like learning things, helping people to heal, helping others. Okay, so there's a theme. Yeah. Okay, I'll keep an eye on that. Engagement with community, looking at data trends. Okay, Jill, supporting others, seeing clients embrace recovery, helping people live healthier lives. Love it. Teamwork. Yes, I'm with you. Teamwork. Community. It's really what that is, making connection. Problem solving. Okay. Thank you for that. I'm going to continue, but I'll be glancing over if there's anything else that comes up. So these are just some of the learning objectives for today. I won't go over them, but you'll have them. It's really a roadmap to the different things we will be covering today. The DSM criteria briefly, and looking at substance use disorder and addiction, and kind of talking a little bit about that. Again, how brain structures and functioning are altered by addiction or substance use disorder, review those evidence-based practices, what research tells us, and then we'll look at one study, a stigma study, and how that impacts treatment and recovery. So we're going to begin by reviewing the definition of substance use disorder and addiction, and including a brief little overview of the DSM-5 criteria. Okay, so let's start with a shared understanding of what we mean by substance use disorder. So substance use disorder is recognized both as a medical and mental health condition. So we're not talking about willpower or character. It's really when someone finds it extremely difficult to control their use of the substance. And that can be alcohol, prescription medication or other non-prescribed medications. And they use them even when they know it's causing harm. It's causing harm in their life. Now, it's also important to keep in mind that substance use disorder exists on a spectrum. Okay, it's not an all or nothing kind of thing. So what the DSM-5 does is it lays out criteria that helps that clinician determine whether the symptoms are either mild, moderate, or severe. And that's going to depend on how many of the diagnosis criteria are met. And that's how we come to that. Now, another thing this spectrum does is it really reminds us that recovery and treatment approaches really need to be tailored. Okay, there's not a one size fits all kind of approach. Okay. So as we're talking about that, so the spectrum, it also means that people might experience the substance use disorder in different ways, and we have to really meet them where they are. There's a lot of fluidity there. Now, as we move through the session, I want us to keep in mind that substance use disorder is a complex, treatable disorder or condition. Okay? And the word disorder or language-like disorder is solely meant to guide care, but never to define the person. And I think that happens a little bit. So in any case, so when we talk about, or as we're talking about substance use disorder, what we're really talking about is a chronic, treatable condition that's going to affect the brain, it affects behavior, and it also affects overall health. But that being said, it's something that people do and can recover from. So that's very important to also keep in mind. So as we build on this foundation that we've started talking about substance use disorder, we're going to also take a closer look at what contributes to substance use disorder and relapse risk. So in other words, we're going to be also tapping into biological, psychological, and environmental factors and how they all come together to both impact or shape vulnerability and recovery. Okay, not separate from that. So let's look at the DSM-5. So we've defined substance use disorder. Let's see how we diagnose it as clinicians. So DSM-5 lays out those 11 criterias. And it's really just to help us understand how that substance use affects that person's life. Okay, and it's looking at behavioral patterns, the time that someone might spend using or recovering, the impact on their daily responsibilities, and even their body's physical responses to that substance. So that's some of the things that it looks at. It also looks at social and physical consequences of the substance use. So what are we talking about? Strained relationships, giving up important activities, or again, that continuing to use even when it's clearly causing significant harm. Now, finally, we have also some of the things that we're looking at are the physical consequences. So needing more of the substance to get that same effect. So they're looking at tolerance, or even experiencing the withdrawal symptoms, those physical withdrawal symptoms when they are not using the substance of choice. Now, the number of the criteria, those 11, that's what determines if that disorder is going to be denoted as mild, moderate, or severe. Okay. Now, it's not really about the label, though. It's really if we can pull out and think about or understand the degree of impact that the substance use is having on that person's functioning, their health, and their quality of life. So to look at it more holistically, how are they impacting? So I am going to ask a question. So as we hear this criteria, we start talking about that criteria. Which one stands out to you as one of the earliest warning signs? In other words, the ones that might show up before things become severe. Okay, just think about that. I'll be glancing at the chat. Give you a little moment to respond before we move on. Not wanting to consider stopping. Okay, Kelly, thank you. Not wanting to consider stopping. I'll continue to take a look at that and continue so we get to the discussion side. Oh, excuse me. Okay. All right. So we've kind of talked about substance, use disorder broadly. We're going to talk about addiction now, which is considered, of course, the most severe form of substance use disorder. So how do we define addiction? So it's usually defined as something that's a chronic, relapsing disorder. And what that means is that it's long lasting and it can involve cycles of relapse, remission, relapse. And if you look at it, it's akin to a lot of other chronic diseases or conditions, hypertension, diabetes for one. It's very similar to that. Now, addiction is characterized by a compulsive drug-seeking behavior and use. Okay? And again, even if it's causing significant harm to that individual. Okay. So we have another not wanting to stop. Let me stop here. Continued use despite relationship or social problems. Yes, again, looking at that holistically. Okay, so back to addiction. So it's compulsive, it's the drug seeking, even when it's causing harm. And what makes addiction especially complex is that it involves long-lasting changes to the brain. And we're going to talk more about that. Particularly those areas that are responsible for things like motivation, reward or pleasure, memory, and decision-making. So these changes, this impact or these changes on the brain is what makes quitting extremely difficult, even when that person deeply, deeply wants to try to stop. We're going to talk more about that. So we say that, addiction is both a brain and mental health condition because it involves psychological dependence, again, the craving, the anxiety when you're not using, and then also the physical dependence, those withdrawal symptoms. Okay? And again, this dual nature reminds us that treatment needs to address both the mind and the body. Sometimes we don't. And also, too, that recovery is not just about stopping the use. Okay? It's really about healing and rebuilding function over time, just like any other chronic condition. Okay, so now I have another reflective question, and when we describe addiction as a chronic brain condition, okay, rather than a failure or lack of willpower, how might that shift the way we think about treatment and recovery? How might that shift the way we think about treatment and recovery, and maybe even compassion, if you think about it? So I'll give you all a second. And I'll glance over at the chat as I see something, and Kelly might keep me honest if I miss something. Okay, but that's just something to reflect. You could keep it in your mind as we're looking at the rest of the information. All right. So now we've talked and we've defined addiction. We're going to look more closely at some what actually characterizes it a little bit more closely. So we talked about that compulsive drug-seeking behavior or use. Okay, so this just means that behavior is driven by very, very, very powerful internal urges. Okay. And as we talk about the brain and how it's impacted, we'll understand that this often overrides logic and any type of intention that you're putting forth. Okay, so we'll talk more about that. Another feature is that loss of control. So people sometimes have the intention to just use once or start cutting back, but then they find themselves in a situation where they really are unable to follow through on that despite their best efforts. Another characteristic is, as we've talked about, that continued use despite negative outcomes. Okay, and that can be physical harm, that can be emotional distress, that can be damaged relationships. And I have to say, this is one of those one of the clearest indicators that that substance use is shifting to more being compulsive. Okay, that's one of those flags, so to speak. Now, underneath all of this, we have those persistent changes in the brain, both in structure and in function. Okay, especially in those areas that control things like pleasure, reward, memory, decision making. Okay, those are the most impacted. And actually, this is what explains why addiction can be so chronic, and then why sometimes even relapse can occur after long periods of abstinence. Okay, I do want to footnote something about addiction. So we use the word addiction pretty widely, but it's not a formal DSM-5 diagnosis. The official term, as we saw, is substance use disorder, and then we categorize that by severity using the criteria mild, moderate, or severe. Addiction really is more of a clinical shorthand, so to speak, to describe that most severe end of the spectrum. That's really what addiction is, or the word addiction, how we use it. All right, this is just what I call my little cheat sheet. So it's just a summary. So I'll summarize this section. So we talked about how substance use disorder refers to a spectrum of substance-related problems, and those range from mild to severe, and those are going to be defined by impaired control and continued use despite harm. Okay. Then we talked about addiction, which is the most severe form of substance use disorder, and that's marked by compulsive use, loss of control, and those persistent brain changes that perpetuate the disorder or the condition. Yeah. Okay. So next, we're going to talk and look a little deeper into how addiction changes the brain. So what's actually happening neurologically, okay, that makes these behaviors so persistent and so difficult to control. And also, we'll see why addiction is now recognized both as a brain and behavioral condition. So let's take a look at the brain and addiction. All right. Okay, so what parts of the brain are affected by the drug use? So this is a great question to really ground our understanding of how addiction affects the brain, not just behavior, but the brain. Okay? And what we see and what research tells us is that there's 3 brain regions that are impacted. The first is the basal ganglia. Okay? And this area controls things like motivation, pleasure, and it's also involved in the formation of habits and routines. So when we experience something pleasurable, we get what we call a dopamine. It's a neurotransmitter spike. And this area of the brain lights up. You know, we see it in PET scans when they're doing research. It just lights up like a bulb. Okay. And that just means that we're experiencing something rewarding. Okay. So these areas form what they call a key node, just an area that is sometimes referred to as the brain's reward pathway, reward circuitry. So that's what these areas consist of. Now, what we know is that drugs overactivate this circuit. Okay, they produce that euphoria of that drug high. Okay, and they're overactivating this circuitry. But with repeated exposure, okay, that circuitry adapts to the presence of that substance or that drug. Okay? It adapts, it builds some tolerance, it adapts to it. And that results in diminishing its sensitivity and therefore making it harder to feel pleasure from anything besides that particular drug. Okay? So the next thing area is the extended amygdala. And this part of the brain is associated or linked to things like stress, anxiety, feeling unease, you know. So during withdrawal, the extended amygdala becomes hyperactive. And this creates a lot of a sense of tension, uneasiness, and that drives people to use again. And sometimes just to feel okay, or quote unquote normal. Okay. Now, this particular circuit becomes increasingly sensitive with that increased drug use. So it's oversensitized, so to speak. Over time, what we see is that a person with that substance use disorder starts using the drug to get temporarily relief from all those discomfort, that angst, that uneasiness, that anxiety, rather than to get even high. Okay? So it's really to dissipate those uncomfortable feelings. We also have finally the prefrontal cortex, and this area of the brain is involved with decision making, impulse control. Basically, it's the judgment center of the brain. Okay. So this area is the place where it powers that ability to think, to plan, to problem solve, to make decisions, and very importantly, to exert self-control over our impulses. Okay? This is also the last part of the brain to mature, as we're growing. So it makes teens most vulnerable because that area of the brain hasn't fully developed. So chronic substance use weakens this area, okay, making it harder to resist those cravings or to think in terms of long-term consequences. So that's why this is important. So really what we see that it shifts, substance use shifts the balance from this area of the brain, the prefrontal cortex, to the circuits of the basal ganglia and the extended amygdala, okay, which make a person with a substance use disorder seek the drug compulsively with reduced control. That's what we see. Now, so when we say addiction is a brain disease, this is exactly what we mean. The circuits that regulate rewards, stress, and self-control become disrupted, making recovery not about willpower, but about the healing brain. That's really what it's about, the healing brain. I'm going to throw out another question, and you can either answer it in the chat or you can jot it down and we can dive into it more when we discuss at the end. So how might knowledge or this knowledge change the way we think about relapse or motivation? How might this knowledge, you're welcome to enter your thoughts into the chat. There's no wrong or wrong. It's just your impression of this knowledge and how that impacts. Thank you.
So one of our prior speakers said that relapse is the natural process of addiction because it is an illness, and like other illnesses, it doesn't just go away. So I'm trying to shift my thinking to it being a cycle and relapse being part of that cycle. And the motivation has to be there all the time, or of course you relapse.
Exactly. The motivation is there, but that's also affected by all this. So that's what I'm saying. When these circuits get disrupted, all of this becomes more challenging. But yes, and I think that's why MI, or motivational interviewing, which is an evidence-based modality or practice, is because they tap in. I'm a metaphor queen, so I hope I'm not bugging everybody. We fan the embers of the motivation, and that's really what it does. And it does so via knowing what we also know, doing it in a respectful, person-centered way, connection. So thank you for that, Kelly. Okay. So let us continue. Okay, so addiction is a brain disease. So we know addiction is now widely recognized as a chronic brain condition. It's not simply a matter of poor choices or weak willpower. And understanding this, is really important to the way we do treatment, understand treatment, etc. But we also need to understand that this knowledge or this understanding is grounded in extensive research. Okay, we talked about just now about how addiction changes the brain. one of the things we were talking about, or I was describing, is how it hijacks that rewards, the reward system or the reward circuitry in the brain. Basically, again, drugs stimulate that brain or that reward system. Very, very powerful. Okay. It can't compete with natural rewards. What are natural rewards? Food, social interaction, intimacy, all of these things that we call them natural rewards that also impact us and are rewarding. But drugs, especially methamphetamine, has such a big surge of that neurotransmitter, that dopamine, that causes that pleasurable feeling, that elation. And it also is linked to reinforcement. So natural rewards can't really compete with that. So what happens with the drugs is that over time, the brain adapts by reducing its sensitivity to the dopamine. Therefore, that's that tolerance where we need more of that substance to achieve the same effect. But it also desensitizes the natural rewards. So we feel diminished, that ability to feel diminished pleasure from everyday activities. So that's important. So that it hijacks that reward system. The drug is the only thing that feels reinforcing. We talked about the prefrontal cortex, which we saw is responsible for judgment, impulse control, decision making. And again, this area shows reduced activity and also structural changes. It changes. And with people who are navigating addiction. And these changes make it harder to resist those cravings and control that substance use, even when they're facing negative consequences. But in terms of memory and learning, so addiction also affects these circuits. And so what does it do? It causes those strong associations between that substance and those external cues, laserly focus those so those get connected, which can trigger those intense cravings and relapse. Yeah. So not to get technical, it conditions you to connect those two. Learning as classical conditioning for those who are have a psych background. So it connects those two. So some of the long-term damages, we talked about persistent and even permanent damages in those brain circuitry. Again, that makes recovery challenging, increases the risk of relapse. And it's not limited to one substance, okay? We see it across alcohol, opioids, and other addictive drugs. So again, we know that recovering some of the brain function can recover with sustained abstinence, especially in younger individuals. They call it neuroplasticity. Their brain isn't fully developed, so there's a little bit more flexibility. Or those who stop earlier in that course of addiction. But that being said, here's the wrench. Okay? That being said, the extent of recovery varies widely, and it depends on so many factors: the substance, the duration of use, individual genetics, and environmental factors. So then it turns into a jambalaya of variables that can impact it. So that being said, and again, I'm going to say this briefly, while addiction is rooted in brain changes, social environment and psychological factors also play a critical role, both in the risk or increasing risk or attenuating risk and in recovery. Okay, so we see things like lack of support or social support, socioeconomic stress, and adverse child experiences. All of these create vulnerabilities to addiction. Okay. So we might have heard of the ACEs studies, adverse childhood experiences, and it tallies a variety of experiences, and depending on the number, that is correlated with an increased risk of both mental health and behavior and substance use disorder in adulthood. All right. But we do also know, just to the positive side, that things like positive social interaction, supportive environments can promote resiliency and recovery. Okay? So we think about this in terms of its implications for treatment. Recognizing addiction as a brain condition, brain disease, supports the use of evidence-based medical treatments, such as medications, and also behavioral therapies, okay? Because this way we're targeting appropriately the biological and the psychosocial aspects of that condition. Again, here I have I like little cheat sheets, summary of brain addiction. So just to conclude, research over the past several decades has firmly established that addiction causes profound and sometimes lasting changes in the brain, and that affects behavior, cognition, and emotional regulation. Okay. So let us continue. These are the evidence-based practices for treating substance use disorder. So some of the behavioral approaches, MI, motivational interviewing, like I said, it really focuses on enhancing that person's or tapping into their own motivation for change, changing their behaviors toward the relationship to substance use. Contingency management, the big demonstration project that California is rolling out. That uses positive reinforcement, things like voucher. It incentivizes or rewards abstinence and other healthy behaviors in a very structured way. CBT, really teaching individuals to recognize and cope with situations that trigger the substance use. And really what it's doing, it's trying to change or reformulate those negative thought patterns or behaviors that are associated with the substance use. Couples, families, again, looking at the larger system and trying to improve the support network for recovery. All familiar with, hopefully, the 12-step programs. And these are several medications that are used for opioid use disorder, methadone and buprenorphine. Naltrexone is also used for opioid use disorder, but also for alcohol. And the last two are used for alcohol. One focuses on or works via reducing the craving, and the other one is a deterrent. You take alcohol, and it makes you sick. So it's behaviorally conditioning you to not, so that's how it uses. But these are the different evidence-based treatments that we know.
Can I ask you a question?
Absolutely.
Have you found any ways to help people resolve the tension that seems to have developed between the 12-step programs and medication usage for substance use?
And that's, I think, is why really looking at what research and it tells us, because we're all, we develop a certain modality or a certain way of approaching something. And I think that is the only bridge. Look, I think that they have tapped into the social and other behavioral aspects, social, that connection. I'm just going to call it this. They've tapped into humanity and tapping into that human being, and all of those person-centered approaches. You can say they all fall under AA, that connection, the support network, the role modeling, all of that. The only other piece of the bridge is how do we fold in what we know now with research and how that works, Right. And I can see where if you look at the history and how it emanates and what we knew then, it's just about integrating new knowledge. We've done it in other fields, in as clinicians, how we treat anxiety, how we treat that. We have learned different things, and the neuroscience. So I guess this is the way I would say it. My bridge would say, let's talk about the monumental shift of knowledge that we've had over the last 12 to 15 years under the umbrella of neuroscience. And let's integrate it, because it's not about who's right, who's wrong, but how can we provide the best treatment for the people we serve? That's what my bridge would be.
Yeah, and it occurs to me that if their provider said, hey, you can do both, then they'll feel more sure to say to their older AA colleagues who say, you're not really sober. Yeah. They can say, oh, my provider said I can do both. And
exactly. Yeah. And it's understanding, isn't that the fabric of, renegotiating knowledge and I don't know, we get set in our ways too, and a certain I mean, we see it not to talk about anything, whether it's just rules or how we see things being in the world. Sometimes it's very hard, to
Yeah.
shift away from
Yeah,
that.
I mean, AA works for a lot of people and has worked, and they want to keep it pure, but
Yes.
Okay,
Yeah.
so sorry to
And
distract you. Go
no,
ahead
no,
with
it's not.
stigma.
It's one of my favorite conversations because I find so much value in that. And it's like, can't we just make a bridge and just, I
Yeah,
think it will happen. I just think this
it's
is me
time.
tipping
Yeah.
away.
I mean, I tell people use all your resources. And guess
Yeah.
what? Those are two incredible resources, AA and medical assisted treatment. I mean, do it. Use it all.
I think that we have to add, you know what I'm saying? That it's like anything else, building and improving. It's not, I think that because it goes to such where the knowledge was and how it was, as the history of AA started, it was, more like a boundary around it and how we understood it. And now it's just how are we going to integrate that? And I think slowly but surely, but that is really the bottom line. Let's look at especially it's been monumental, not only for substance use disorder, but for other treatments, mental health as well. Neuroscience has totally, so much information. It's been exponential over the last, I would say, yeah, 15 years. Thank you for your question. So now we're going to briefly talk about the impact of stigma on treatment and recovery. So we're going to see what research tells us about stigma on treatment both and recovery. So what research tells us is stigma, negative attitudes, stereotypes, discrimination towards individuals with mental health and or substance use disorders has a profound and far-reaching effect on both treatment and recovery. Research says this. I'm highlighting one study because it seems so subtle. Language. Let's look at language. So this study basically looked at an individual, same individual, and the only difference was, excuse me, is that they either referred to that individual as a substance abuser or having a substance use disorder. That was it. That was the only difference. And what they were looking to see is, what did that evoke, in terms, and they were looking at for them to uh, judge or give their opinion or their perspective on different arenas. They called it behavioral self-regulation, social threat, and to evaluate if they were recommending treatment or punishment. Okay, so again, the study discovered that participants, okay, that where they used the word substance abuser, how did they react, or what did they say about the substance abuser was less likely to benefit from treatment. That was how they perceived it. More likely to benefit from punishment, more likely to be social threatening, and more likely to be blamed for their substance-related difficulties, and less likely that their issue or their problem was a result of an innate dysfunction over which they had no control. And also, they also saw the quote unquote substance abuser more able to control their substance use without help. Okay. Such a subtle change. And you know what the real, I mean, even for me, this is what really, when I first heard about the study, even highly trained mental health professionals, that exposure to those two words, they're not free of those same biases and responding in the similar fashion. It didn't make a difference if it was a very trained mental health professional or not. And that is very powerful in terms of what stigmatizing, the carryover that stigmatizing language can have. Okay. So this just goes over the impact of stigma on treatment. It summarizes what we know, how it keeps people away from treatment. They don't want to be labeled. They don't want to be judged. What else? We also see that it also shows up in healthcare. Yeah, it's not just society, but in healthcare and these unconscious biases even that sometimes might be unintentional really impact quality of care and the quote unquote warmth level of interaction. And again, just like we saw in the study, what we might extend to that individual really has an impact on that. In terms of recovery, okay, we're focused usually on the treatment and the coping strategies, but stigma can even have an impact when somebody is recovering and they're in recovery. Recent research consistently shows that stigma is linked to things like higher psychiatric symptoms, lower quality of life, and poor overall social functioning. Okay? So it doesn't only affect how we treat people, it can also affect how people see them feel about themselves and
Yeah.
their
I
ability.
find it so amazing that the personal internal stigma may have more of effect even than what people say on the outside because it's been internalized.
Yes.
And
Yes.
so hard to change that thinking. You have to be very active and recognize what you're thinking. And when you're just wanting substances, you may not be paying that much attention to what you're actually thinking about things, you know. It's just amazing.
Yeah, no, it's amazing. I don't want to digress, but there's some depression studies where they were looking at because we know well, maybe I'll save it to the end, but there's that perception overrided quote unquote actual supportive networks. Perception. It's interesting. I can talk more about it after, but it's a very, to your point, yes, perception. And that's why cognitive behavioral therapies and deconstruction of like thought patterns and so forth is such a powerful evidence-based kind of modality for not only for substance use disorder, but others. This just highlights the types of stigma that we see discussed in research. So public stigma, what most people think of first is really, again, it's what society holds for certain people, those biases. For example, addiction is somebody who's weak, they're dangerous, they're morally flawed, etc. Again, self-stigma, as Kelly said, what we internalize, those negative labels, those negative narratives, and that makes us feel ashamed, hopeless, unworthy, etc. And then the structural stigma, which just really shows up, that's more of a macro, shows up in policy, laws, funding opportunities or priorities, etc. The larger society. And I love my little cheat sheets. You have one at the end of all, and it just summarizes. I'm a visual person, so I think it just kind of takes that and gives you a summary. So when you look back, it's a lot of material for a short time, so it gives you a little cheat sheet. So again, really the takeaway is that stigma is a major barrier to effective treatment and sustained recovery, okay? For individuals both with mental health and substance use disorders. And I think that's the big takeaway, that we need to understand how impactful it is. With that, I open it up for questions. Any questions that you might have, we can revisit some of the other questions. There's references for further reading. I won't go there now, but just so you know, you have references here and a lot of material that you can dive into for more detail if you should be interested in, just looking at more information. Open it up to any questions or comments or takeaways that you have from today's chat.
Did you see both of the chats that came in?
Oh, I didn't. I closed it. Let me see.
Very, very inspired, I would say. I like them.
Okay, let me see where I left off. Okay. How might okay, that was the question. And then Naomi said, understanding that there are organic changes in the brain may elicit more compassion in others. Yes, definitely. When we see how it impacts someone. We don't get angry at somebody for developing a chronic illness. We what do we do? Thank you, Naomi. Yes, it's a reframe. And to Kelly's point, perspective and perception is such an important factor, how we formulate things. Mary, decrease stigma for clients and providers. Let me see, cut it off.
I think that was when we were talking about the AA and the MAT.
Oh,
I'm not sure.
you see, Mary, it decreased stigma for clients and providers. See recovery as a long-term process management instead of a one-time event.
Oh,
Oh, okay, go
that
ahead.
was about the treating it like what was it about, Mary? Help us out. Hmm. Oh, instead of oh, the recovery
Like a
cycle.
brain disorder. Okay,
Okay,
yes,
yeah, yeah.
yes. When I was talking about, yes, and you highlighted something. Thank you for that, Mary. Yes, when we start looking at it, Kelly, you also mentioned, like most chronic illnesses, they have a cycle of being okay and then not being, it's the cycle of remission and then relapse or an activation of the chronic illness or the disorder. And I think that that also gives us a different perspective. It's not an all or nothing or we've wiped the slate clean and yeah, and this is what we do. So I think that that's also important. Again, it formulates how we see things. I mean, how we formulate perception, I mean, not only impacts, like we saw, how we respond to people, but it also impacts, as Kelly highlighted, how we see ourselves, because we take in those narratives and we internalize those narratives. And that is not separate for how we see it in research, how treatment and recovery is going to be impacted by that. It's like a fabric, we see it. There's so many connections, and this is what it's about, peeling those layers and understanding those connections. I think for me, that's what it's been as I learn.
And I like something you said about recovery resources because we had a speaker from Kentucky and he had lived experience and he compared his life, which was um, maybe more supported. He didn't have any aces. He had everything he needed his whole life, but then he took some painkillers and that was it. And he just could not get off of them but eventually he used his resources, his recovery resources, and he was able to. And now he tries to provide those for others. And it really made me think because he said something. He said that probably addiction in college students is much more prevalent, but when they leave college, they get a job and they have the resources to stop using.
Mm-hmm.
And that was kind of mind-blowing to me because it kind of sounded like my college, but but then you had to stop. I was in medical school, you can't do
Yeah.
that forever. But how can we give everybody the resources they need is just overwhelming. I'm sure politicians would be like, "Oh no."
Yeah, exactly. And that's why the framing is so important. When we talked about, I'll go back to the types of stigma. And when we look at the structural stigma and how laws, policies, institutional practices are all impacted by the narratives we create and the beliefs that we have. So that's what we see. That's a great example of that, structural stigma. That's where we might not prioritize funding for mental health or substance use disorder because we have certain biases and so forth. So yeah, like I told you, it's a web, and we have to a lot of public education and continue the research and trying to connect that research and our knowledge to that other side. I see comments coming in. Let me just see. Um, oh,
Oh,
Bruce.
recovery
Oh,
capital with an OL. That's true. That might have been Freudian on his part, Monica.
okay.
Um, and then Dr. Sheehan put in the health.gov, healthcare.gov site, and
Uh-huh.
it shows that recovery services are available. They're supposed to be available for everybody on, I think, Medicaid and Medicare. But recovery capital, a place to live, clothes to wear, a shower, food, support, things like that,
Mhm.
can't we can't really we can't ensure that, right?
No, no. And
Yeah.
then even if you have programs, sometimes the just the great need overwhelms that, and then it becomes more of a programmatic and waiting list, no connections, and the infrastructure.
Oh,
Um,
and you know what we have here? You
huh.
have to have some substance in your bloodstream to get admitted to rehab. But you can't get into rehab within 3 months of wanting rehab. So if you happen to
Yes,
do AA and MAT and be sober,
yeah.
or you can't get into rehab once your name comes up on the list. I mean, craziness like that.
And it's where it's that disconnect between the programmatic and the need. And we find that I mean, not only in substance use disorder, in mental health as well. But yes, definitely I see in terms of my experience in substance use, there's such a disconnect with that. We're these are the rules, but they don't really take into consideration. See it
Mhm.
also with some of, well, here in California, the M House situation as well. We see that the disconnect in terms of the monies and funded and programs and how it can really reach the people who really need it. I saw that there was a question.
Yeah,
Their
there's one up there.
politics or just general fear of behaviors. Is that I'm not really sure. Is that a question? I don't know if you're a male, female,
There,
but
there are there are a fear politics or just general fear behaviors. Are there fear politics? Well, we have nothing to fear but fear itself, right?
that's true, Kelly.
But um, general fear behavior, fear on the part of the politicians, maybe fear, well, fear of spending money, fear of it taking away from others. There's so many, I,
Yeah.
I think, fears involved in politics.
And when things are stigmatized, to saying it's like you don't want to align with something or be
Right.
looked as someone who is acquiescing to certain
Right. You're a
things.
drug lover. You're a
Yes,
druggy lover. Oh,
exactly. And those quick, and now with, just the way we communicate now in these short bullet sound bites, on social media and stuff, and that, it takes off. So yeah, I would agree with that. It's a fine line and it's hard, to talk about that because that could be the stigmatization. So, I think that's where we start
yeah.
understanding that and trying to deconstruct that because I think that's very powerful. We saw that just with one
Mhm.
word, substance abuser versus a person having a substance use disorder, and people who are trained do not escape that
Right.
type of,
And
yeah.
so if you're a politician, you're even more
Oh my
subject to
goodness.
stigma and expectations. And so I could see why that would be hidden. Yeah.
Yes, absolutely.
And then Nista asked, readiness for change is imperative and timing unpredictable. How may macro structural support may be actualized? I think it's how could structural support be actualized? That's an excellent question.
Then it is readiness for change, imperative, and timing and predictable comment and map. Yeah, that is an I think that's kind of a bifurcated. So this is since I'm in like the academic side, my thing is how do we educate, and highlight these things. And I think, Kelly, that it's a whole different world, the political world, and people and sometimes there's other priorities, getting reelected, aligning this, that. So I think it's a big bridge. But I think voices, advocacy, leveraging that. And I think that's the only way. That's the only way we've always impacted macro structures. But we're in my world, it's comes from understanding and putting seeding. I like to say seeding that knowledge out there that can take place and then actualize through the system too. But it's a complex system, and this is a very complex. It's one of the most stigmatized disorders that we see. And it's unfortunate because as we see today in the chat, both the self stigma and the structural stigma, as well as the public, but the all of those come together and create these barriers to funding, to even looking at revamping, it's bad enough going into a public sector, very complex, very bureaucratic system and trying to make any changes. On top of that, we have the layer of stigma, which can create a lot of barriers. That isolation that you even families, we saw that families of people with substance use disorder, they also are stigmatized by association. And so that's why I brought up the topic of stigma, because I feel it's like a weed that we don't always talk about, but has large impact.
Yes, so true. So if we change, and okay, so the biggest thing I took away in response to your questions was, if I were to say to a patient, um, you need to use all your resources, go to AA, get on MAT. When AA tells you, because they might, that you
Yeah,
can't be in AA if you're on MAT, you say, my doctor told me I can do both, and I will.
yeah. And that's basically, yeah. It has to start somewhere. I mean, in terms of at the individual level, we would not offer, we would not deny anybody evidence-based care in any other condition. And that's why would we do that for such a complex condition that is, wreaking havoc on so many lives. I just, it doesn't make sense. That is my take. That's how I formulate it. And I hope that resonates for you all.